My name's Christopher Boos. I'm a consultant cardiologist. I used to be in the army. I left 5 years ago for many reasons, one being that pension, a lump sum, became more and more attractive because I was on the old scheme. And the higher you go in the military, the more command they wanted you to do, and less being a doctor. And while I was in the military, Alex Bennett, who is the chief investigator of Advanced, approached me about this exciting study, and we started, the two of us together, and then it grew from there. So I've been Advanced from the very beginning with Alex, but I'm a consultant cardiologist, and this is probably why I'm first author on this paper, because it's quite cardiovascular. Okay, so the title of this talk is the title of the paper that was published about a week ago, and it's the relationship between combat-related traumatic injuries, so CRTI, and cardiovascular risk, and this is data from the Advanced study. The slides are, oh, here we go. Okay, I'll just go back one. So why did we do this study? Well, there is historical data to suggest there is a link between combat-related traumatic injury and adverse cardiovascular disease, or CVD, outcomes. But when you start to look into the data, it was predominantly amputees. Virtually all the studies were retrospective, meaning people died or things happened to them, they look back in the timeline. They look backwards, not forwards from the time they were injured. Or they were cross-sectional, meaning you looked at 20 amputees who had hypertension and 20 people who did not have amputations, and you compared them. Well, you're not really comparing like with like properly. And these were tiny studies. And virtually all the studies I looked at were related to injuries more than 40 years ago, predominantly the Vietnam and Second World War. So how on earth does that apply to modern warfare, where you literally got coming straight at the front line, people are on all sorts of different treatments, battlefield care? You could not possibly use that data to talk about today. It's just so different. So what I did was I hired a master's student, and we looked at the evidence, and we sourced 4,500 papers from the literature. One of the most, it's worse than a bad marriage. We found 26 manuscripts, and we had to look through 130 of them, including one in Russian. And we identified 26 manuscripts of the quality needed to say you've done a study properly. You could look at who, etc., how, when, and why. And the data was really inconsistent. In other words, they cited some links between injury, predominantly amputation, and cardiovascular events happening, but it really was uncertain when you look at the quality of the evidence. So this is where Advanced comes in. So its aim was to investigate the long-term physical and psychosocial outcomes of battlefield casualties from the Afghan war, and to use this knowledge to try and support the best care for our injured service personnel. So that's the wider aim of Advanced at its inception when we first started. And what's different about it, it's prospective. In other words, we get our cohort and we follow them up through time. There's no other study like this in the world. They are questionnaire studies, but they aren't studies where people are coming in en masse to do a bunch of different physical measures. So related to this paper in particular, the general hypothesis is that there may be a high level of comorbidities, quality of life and mental health may be affected, and this may lead to poor functional social employment outcomes. But within my specific paper, my hypothesis was, if you're injured and you're able to walk less well, surely you're going to put on weight. That seems common sense, but it may not be the case. If you put on weight, then quite often your fats and your blood may go up and your sugars may go up. That happens in general cardiovascular conditions. And with that, your blood pressure goes up. And with that, your arteries can become stiffer with age. And with bigger bellies, you can get inflammation. It's like a low-grade inflammation going on in the vessels. And that is a prerequisite to atherosclerosis, which causes strokes and heart attacks, etc. So basically, the hypothesis, in my mind, you're doing less well in terms of activity because you're injured and a host of other things happen. Now, it may not be as simple as that. Of course, we know that. You may have post-traumatic stress disorder. You then decide to go for different diets and, loads of different things in there that could happen. But the aim of the study is not to get into that depth. It's simply to look at, you're injured. How do you compare to the non-injured? And does the severity of your injury dictate the cardiovascular risk? So we did aim for 600 injured, and 600 non-injured, but the pandemic definitely kiboshed that to an extent. So we felt to close recruitment at 579 injured and 565 non-injured, who were frequency matched by age. So they were similar age. The aim was to be of similar service, similar rank, similar regiment, all in Afghanistan in a similar role, so that we'd have the same number of paramedics, same number of infantrymen, etc. Just so you're aware, though, we had a pool of several thousand injured, several thousand uninjured, and we grabbed from equal minds, equal type. But we can't then control who decides to come forward to be part of the study. So in other words, we have frequency matching, but when it finally gets down to who turns up, that may skew things. And we did several measures, and you were all part of this. You turned up at Headley Court and then Stanford Hall, and your height, your weight, your abdominal waist circumference was done. Your injury severity relates to the injury severity at the time you were injured in Afghanistan. There was a specialist nurse in Afghanistan who looked at your injuries as you turned up to your battlefield, A&E or whatever it was, and they graded your injuries at the time, okay? So this isn't a reflection of the injuries at the time we saw you in advance. It was the injuries at the very time you were injured. And we did a bunch of blood tests on you, as you probably remembered, and asked you so many questions that you really loved answering about your pets, your family, your financial position, unbelievable levels of questions. And we put you in a machine like this, so it measured all sorts of clever information about how dense your bones are. So in the future, we'll be able to say whether you're at lower or higher risk of osteoporosis, how much fat you have in your lower abdomen versus your chest versus your bicep, etc., called body composition analysis. And I was interested in this concept called metabolic syndrome. Has anyone here heard of it? So metabolic syndrome is the presence of 3 out of 5 of the following cardiovascular risk factors: bigger tummy, higher sugars, or being on medication for diabetes, having increased fat of this type, lower fats of this type, or elevated blood pressure. You need to have 3 out of 5 of these. And it's sort of an invisible risk factor. You need to go looking for it to identify it. And the other thing we did in advance is, if you remember, we put this cuff on your leg and something on your neck, and we measure the speed at which blood moves down your body. The faster it is, the harder the arteries. And this is called pulse wave velocity. It's the most robust measure of artery stiffness. But there's a second form of arterial stiffness using pulse wave analysis that gives a measure called augmentation index. It's not as robust as this one, and that'll be relevant in a second. So here was our group: 565 non-injured, 579 injured. The matching by age was brilliant. No difference. Any p-value that's less than 0.05 means there's a difference. So we got really good matching for age. Your average time from deployment or injury or being in theatre at the same time as the injured was just over 8 years and 98 months. If you were non-injured, 3/4 were still in the military. If you were injured, 2/3 weren't in the military. So you're much more likely to be out the military if you're injured. We had far more non-officers than officers, and I can tell you at the very extremes of rank, the lower ranks, there were far more injured in the lower ranks. So there was a definite skew there. There were more privates and lance corporal equivalents in the injured group, despite our best attempts to match. It was a predominantly British, white, Caucasian population that we looked at. Only 9% were of other ethnicities, and very few had a family history of heart disease, cardiovascular disease, meaning your mother, your father, your sister, your brother had a heart attack, stroke, or died of a cardiovascular death. This was predominantly a study of blast injury. And in terms of mechanisms, just over 1 in 4 of the entire advanced cohort had lost 1 or more limbs. Okay, so but it was predominantly lower limb amputations in virtually everyone. It's nice to see smoking currently was quite low across the board and no difference between the injured and non-injured groups. Now, this is a busy slide, but I'm just going to keep it simple to look at the left, the uninjured versus the injured. As you can see, waist circumferences were 2 centimeters greater in the injured versus the uninjured. Oh, by the way, feel free to interrupt if you've got any questions. Visceral fat area, this is the fat right in your tummy, deep into your tummy, was nearly 10% greater in the injured. Physical activity was lower in the injured. And by that, I mean people achieving the physical activity recommendation of 75 minutes of vigorous exercise a week or 150 minutes or more of moderate exercise a week. Okay, so this wasn't in terms of total amount of exercise, this was achieving recommended amounts of exercise. This mark of inflammation, CRP, was marginally high in the injured. There was no difference in total cholesterol. The good cholesterol, so you want to have high good cholesterol, the good cholesterol was marginally lower, but statistically significant. I mean, it's minusculely different, but statistically significant. Fats, called triglycerides, were higher, but it's only marginally higher, but reaches statistical significance. The injured had higher heart rates, no difference in blood pressure, absolutely no difference in the gold standard measure of arterial stiffness, which I call pulse wave velocity. But the secondary indicator of arterial stiffness, called augmentation index, was higher. And 11.8% of the uninjured had metabolic syndrome. 18% of the US population of a similar age would have metabolic syndrome. Just so you know, 18% of the average American of this age would have metabolic syndrome. And in the injured group, it was 18%. So it was 50% higher, but no different to the average American, but basically showing there was more metabolic syndrome in the injured and uninjured. Now, if you go by NIS, which is your injury severity score at the time you got injured, this data in the injured group was driven by the more severely injured group. Okay, so for example, metabolic syndrome in those with the less severe injuries was 15.2%, but it was 20.7% in the more severely injured. Augmentation index highest in the people with the most severe injured. The fats here, much higher in the people who are more severely injured. And there's a similar story across the board. HSCRP was almost identical, this is inflammatory marker, if you had minor injuries to the uninjured. It was the more severe injured where these numbers became more dramatic. And all I want to say with this busy slide, and I apologize for this slide, it's a bit laziness on my part. All I wanted to say on this is what was driving the diagnosis of metabolic syndrome was waist circumference, lower good cholesterol, and higher fats. There was no difference in sugars or blood pressure between the injured and non-injured. That's why these p-values are not significant. Okay, so I said you needed 3 out of 5 criteria to define metabolic syndrome, and these were the 3 criteria driving it. But no hint of diabetes or early features of diabetes, no difference in blood pressure. So, in conclusion, the data here suggests that combat-related traumatic injury is associated with an increased risk of metabolic syndrome. And the critical features pushing that metabolic syndrome diagnosis are increased abdominal waist circumference and visceral fat, and more dyslipidemia, defined as lower good cholesterol and higher triglycerides. And I will just say that triglycerides are not as strongly related to cardiovascular risk as cholesterol is. So that is an encouraging thing in a sense. There was increased arterial stiffness defined by augmentation index, but not by the gold standard pulse wave velocity. There was more vascular inflammation. And the final bit is to say, this was influenced by injury severity. And when we adjust for rank, age, socioeconomic class by rank, and physical activity, this relationship I showed you above remained. So in summary, we have very early subclinical indicators of increased cardiovascular risk, not disease, risk, not disease, on only a few bits in the injured versus non-injured, and it's more noticeable in the more severely injured. And I'd like to acknowledge in closing all the funders and yourselves, most importantly, for helping take part in what is a landmark study now that's created enormous amount of interest. And I would just say in closing, Medscape is the top information pathway for medical information in the world. And this study came in top 4 in Medscape for news. Whether they're trying to sensationalize it, I don't have a clue, but it was found to be extremely newsworthy. So thank you for your time. I'm ready to take any questions.
Christopher, thank you so much. That was incredibly informative and I think very useful, both the way you've analysed the results there and the slides that others will get to review. Yeah, I find it really positive that there's not too much significant change in the injured and uninjured, though there's still room for some kind of improvement or action. So I guess a question or a suggestion would be, obviously in the uninjured, in the injured cohort, it's clearly identifiable that they're at an increased risk. And I think with the severe group, that goes hand in hand. Perhaps, if they're struggling managing their pain or their medical condition, or their psychological state is compromised, and depression sets in, obviously that creates less movement, less desire to move, motivation, and that kind of goes hand in hand. And the same with physical condition, managing the chronic pain. So they're going to be less active. Something that's always stood out for me is obviously in the military and those that still serving, all of the wellness piece, nutrition, all that stuff is taken care of. So you have a plentiful diet, you can do as much exercise as you want. You could probably eat relatively poorly and exercise to work that off. But in the injured cohort, once you've kind of been through Headley Court or Stamford Hall, you're kind of on your own pathway. A suggestion would be some lifestyle improvements that can reduce that risk factor for the injured cohort. So can we have maybe some education pieces as part of the visits to the advanced study, some nutritional advice perhaps, some wellness information, just to help people along their journey in case they have got into a state where they're moving less, their waist is getting a bit bigger and they don't really know how to get out of that cycle.
So Ryan, that's a very good point you raise, and I hear everything you're saying, and I think we probably need to do that in part, but can I just give you a separate angle on this as well? If somebody's overweight, we should be telling them they need to lose weight. Sorry, I don't know how I'm going to answer this. But the first thing I'm going to say is just to remind you that all the risk factors we identify are modifiable. Clearly, if you have an amputation, you can't get your limb back, but you can have a prosthesis. But increased weight, you're right, we can do with diet. If we get diet right, that big tummy almost certainly is part of driving that inflammation, the arterial stiffness. Stress and all that could be triggering it as well. Of course it could. Alex said, Christopher, are we at the stage of now bringing in a huge lifestyle intervention to advance, targeting the injured? And I said, I'm not sure we can do that quite yet, because we could change the science, because we've only got a preclinical signal. I'm not waiting for people to have strokes or heart attacks. Of course I'm not, but this is only the baseline. So I've said to Alex, I think we could be giving them good lifestyle advice, like they could do more exercise, etc., if they can. But if we bring in a unilateral health promotion to the injured, there is a risk which could change the science and obscure the results in a way that we don't understand what the data shows. And trying to get that balance right is difficult. And the reason I say that is we do not see a difference in pulse wave velocity. We do not see a difference in blood pressures. We do not see a difference in cardiovascular disease at this stage. So I said, we can talk about it now, maybe we need to do it, but certainly follow-up 1 will be crucial, because we do not know if these differences are baseline biases. In other words, we brought in more lower ranks. There are more lower ranks in the injured group, and lower ranks have certain behavior patterns, as you know, in the military that keep going in later life in terms of alcohol, behavior patterns, diet, etc. And so whilst I hear what you're saying, if somebody's obviously fat, we need to give them some health promotion, but we have to be careful how much we do, because we could obscure and bias the entire data going forward in terms of what it means. But I hear you. And if we don't do this early, we'll be culpable in a sense for not taking a responsible approach. So I probably haven't answered your question right, but I think we need to do something, but the question is how much.
Yeah.
I'd like you to come back on that, Ryan, see what you have to say on what I just said.
Yeah, no, it makes perfect sense. We are at a tipping point here. I totally get, you know, the risk of obscuring results and therefore the findings long term. I guess, yeah, I mean, also, I work with veterans all the time, and for me, there has to be some, you know, self-reflection, and they need to be responsible for themselves as well in changing and getting the best out of their futures and pathways. So there's only so much you could do if the advanced study was to do anything in regards to like education and stuff. So the individual still needs to be ready for that change and take ownership of that. So yeah, I get what you're saying. Maybe there's something that can be done, but just, yeah, it's the quantity of that is
Right. Very much my understanding, the plan in place with time is very much to make that a crucial part of the advance. Absolutely make it part of the advance. In other words, we continue to follow you up for your 20-year lifestyle, and we plan to make health promotion a crucial part of the advance. But are we at the stage to do a full-scale health promotion onslaught? Data wouldn't suggest that quite yet. And I think getting the wearable technology into the next phase of advance, which is where I'm at now, so we have a better understanding about exercise, because those activity questionnaires you guys were asked are very nebulous in terms of your recollection. If we can, because as you know, there are amputees doing ridiculous levels of exercise, really loads. Maybe isn't the exercise driving this process? It could be health related, other behaviors like diet and the injury itself. So I think more data from this study will help in terms of how we target that lifestyle advice, because we may be able to be more precise in what we target based on the health, the mental side coming out, the osteoporosis side, all those other factors will then build the pieces to allow us to give us more precise health promotion, I think, as well. Do you want to say anything, Michael?
Yes, yeah, it pretty much Rand touched on a bit of a question that I was going to say. Obviously, because you've got your control group that is mainly still within the forces, are you looking at doing like having a bit of a subgroup within them as they discharge, and you can maybe see after so many years if there's any changes post-discharge with them, because then we'll probably see if there's actually a relation between the injuries that have caused potential cardiovascular problems, or is it actually post-discharge? Because like you said, there is amputees doing a lot of exercise compared to like myself.
That is a phenomenally important question, actually, that I hadn't considered. Is it just being in the military family, like Ryan said, and that diet and that ethos of exercise that's driving this? And the fact is, from what you're saying, the injured are doing worse just by the fact they leave the military and they're exposed to civilian life. Gosh, you see, that's the thing, we don't know. And that is a good point. And so maybe in the follow-up, we do need to do subgroup analysis. And this is where, if we do too much at the beginning, we could change the science and never fully understood in the first place. We have to be careful. That is a very good point. I like that point. Very good points raised. In terms of what's happening next with this study, because I know that question has been put forward, we have now just sent all of one frozen down blood sample that you all gave for the injured and non-injured, and that's currently sitting in a lab in the United States, the top proteomics lab in the States. And they can measure 7,000 proteins in the bloodstream and look at its relative expression of these proteins in the injured and uninjured and see which proteins may be expressed more to give us further insight into the cardiovascular risk. We are pushing hard for wearable technology so that when you guys come in the future, I'd like to see that you guys leave with a smartwatch that you can't keep because it'll be too blinking expensive, that you borrow for a month, where you can't see what's on screen. So then we can capture exactly what you're doing in terms of your sleep quality, exercise levels, all these other stress level markers, because I think the health questionnaires have left us confused. And that would also help answer the question, Michael, you said, the military versus non-military cohort in terms of exercise. I think that would be really useful.
did any of the results from the, I know you said we had a low sort of different ethnic group section compared to Caucasian, but did any of the results indicate a higher risk to ethnic groups that were already predisposed to cardiovascular problems, such as Asians and Indians and things like that?
So we adjusted for ethnicity, and it didn't change the results. However, we already know that South Asians and Black Africans are at higher risk of metabolic syndrome in general, because their body shapes are different. And South Asian diets with a lot of ghee and curries, etc., they're at higher risk, but we don't have enough of them to be able to show that. But the chances are they will, if they follow the typical South Asian diet. And if you are a Black African, your body shape alone puts you at increased risk of metabolic syndrome. So they're at higher risk. Quite a bit of the science that's been involved in advanced have been shaped by you as individuals. And we get that all the time. Alex and others come up with new things, including from the research nurses. And that's why we have to go for ethic amendments, because you guys are helping to shape the study as it goes forward. I mean, it's your study, it's not my study. It's trying to help people going forward. That's the whole aim of Advance, okay, is to try and make lives better for everyone. And so thank you very much, Maya. I'm going to sign out and deal with social care on the wards. Thank you. Bye.